This is I think the third or fourth time that we specifically talked about screening for psoriatic arthritis in our patients that have psoriasis. It's one of the first questions you should ask once you determine that the patient has psoriasis. Sometimes, if you're not sure they have psoriasis, finding out that they have psoriatic arthritis or family members with psoriasis and psoriatic arthritis can actually help you make the diagnosis of skin disease. So this is called the PsA test. It's a psoriasis epidemiology screening tool for psoriatic disease. You can actually have this printed out or digitally give it to your patients before you even see them. They can check the little boxes for the joints that they have involved, and then they can answer the questions. The answers to these questions are yes, no. So have you ever, and Dr. Armstrong did a great analogy of this earlier with the PsA. It's a very similar idea. You're screening for psoriatic joint disease. So if you get 3 out of 5 positive answers to these questions, then you have a 91% sensitivity that this patient has psoriatic arthritis with a specificity of 84%. And so these are simple, easy questions you can ask while you're doing your exam, or you could have the patient fill it out ahead of time. Have you ever had a swollen joint? And this is yes or no. Has a doctor ever told you have arthritis? Yes or no? Do you have pits or holes in your fingernails or toenails? Have you ever had pain in your heel? Because how many patients have plantar fasciitis? How many of your psoriasis patients have had plantar fasciitis? Maybe it's psoriatic arthritis. Maybe it has been psoriatic arthritis for a long time. So that's a yes or no. Have you had a finger or toe that was completely swollen and painful for no good reason, right? Do you ever wake up with a hot, swollen finger or toe, like a sausage digit, dactylitis? That's what you're screening for. It's a yes or no. So if you have 3 positives, you have a really good documentation with a high degree of certainty that the patient has joint disease also.
This is also downloadable from the National Psoriasis Foundation on their website as well. All right, we're going to move into our next section, which is hot off the press in psoriasis. We're going to have Dr. Armstrong run through the first section here.
Yeah, so we went over kind of the mechanism of deucravacitinib, also known as Sotyktu, in a bit detail in the earlier discussion. So here are some kind of more practical tips here. So a few things is that it comes in 6 milligrams once daily, and the patients can take it with or without food. That being said, they shouldn't cut the pill because it's not made to be divided. Few things, if you look at on the right-hand side, so this is the common AEs on the right-hand side. In the studies, they did show some increase in blood creatinine CPK levels. The significance is unknown, and those that had the increase typically was associated with some kind of sporting event and usually resolved after that. There were low rates of herpes simplex or mouth ulcers. Most did not lead to discontinuation of the medication. There were also low rates of folliculitis and acne, not in the rates that we see with JAK1 inhibitors, but there were low rates in the studies. Also, most of those did not lead to discontinuation. One of the things about deucravacitinib, I think that kind of shines, it's this good tolerability profile. Very well tolerated. Patients usually do not experience much nausea or vomiting. In fact, if you look at the trial rates, nausea vomiting rates were either the same as placebo or lower than that. And it's being explored for actually IBD as a way to treat potentially IBD. Next, please. Okay, so I showed you the clear, almost clear data. This is PASI 75 response rates, as you can see here. The main point of this is that it still goes up after week 16. So as you can see, nearly 60% PASI 75, and then nearly 70% of patients achieving PASI 75 at week 24. And the black line is the apremilast. So if you have a patient asking which oral medication performs better, we have head-to-head data that pretty indisputably talks about the difference in efficacy now. Okay, next.
All right, so what labs will you check for initiation and then ongoing monitoring? We touched a little bit on this, but.
So for this specific agent, according to the package insert, and if you read through all the clinical trials, prior to initiating, so if you have a patient, you say, yeah, we're going to use this oral medication, it's once a day, we're going to get some baseline screening. The requirements would be baseline TB, and then baseline hepatitis B and C serologies. Now, I can't tell if a patient has severe liver disease when I look at them unless they're completely orange. But it's in the label. So the requirement really, if there's no known history of liver disease, you do a screening for TB and then hepatitis B and C screening, and then you can get patients going. The cool thing about this particular agent is that they have the sample pack. It's a 1-month sample pack. So once you get those labs back, they can have medication in hand to get going for the month that you're kind of getting the access to the medication for them. Ongoing management, none is required, but obviously you do what's in the best interest of the patient. The other thing is, if this is a biologic naive patient and you decide you're going to go with this medication, we're hoping and assuming this medicine is going to work and this patient will be able to stay on it for a long period of time with great results. But unfortunately, sometimes that doesn't work out. So it wouldn't be a bad idea to get a really good picture of the patient's overall baseline health status, similar to what you would do prior to initiating a biologic. That way, if for whatever reason you do need to switch gears, you already have those baseline results in your chart notes.
Yeah, I agree. I happen to be a big fan of package inserts. I think a lot of work goes into making them. I think where they fail is here. There's no face validity to saying ongoing monitoring of liver and triglycerides if you have no baseline. Like, that's just ridiculous, right? How do you possibly know any of those things without doing them prior to initiation, right? So you should do them prior to initiation. So if the triglycerides come back at 375 and you have no baseline, how do you know if it's drug-related or not? You have no idea. So I think it's useful to get a more comprehensive baseline series. I just sleep better knowing that, and you have a good sense as to the general health of the patient you're putting this on. The CPK we see with JAK inhibitors, right? And it's working, it's a kinase, so it's working there. I'll tell you where my issue is with these, both the apremilast and deucravacitinib, is what patients do you start them on? What patients get these drugs, right? And I know no one ever likes talking about it on the panel because it's such a hard thing to do and try to be really fair about it, but so you have a drug that's twice as effective almost as apremilast. It's way more tolerated, but it is not as effective as 4 shots a year of an IL-23. And so I know that I hear the shot thing all the time. I don't buy it for a second. I think needle phobia is 90% provider needle phobia, not patient needle phobia, because last I checked, patients can't get an Ozempic prescription filled because it's out of stock. The Mounjaro's out of stock. And guess what? You got to inject that every week. And people seem to be just fine with it, so much so that they're willing to take it from the diabetics, right? So maybe needle phobia isn't real the way we think it is. I'm sure it's not real, because when I write hundreds of biologic drugs in the 10016 area code in New York, which is maybe 4 blocks wide, And then there are providers 1 block away from me that have nobody on biologics, and the excuse is because the patients are needle phobic. They live in the same building as my patients do. So it's no, you're needle phobic, or you don't want to have that conversation with the patient. Not that the patient is needle phobic. That's my personal opinion on it. So when do we use it? I do write these drugs, by the way. I do write them. I tend to write them a little later on rather than earlier on, or I find them useful when I have a little trouble with clear plaque psoriasis as a diagnosis, because deucravacitinib has a very interesting mechanism of action that can be very helpful. But that's how I look at it. I don't know if you guys look at it a little bit differently.
Yeah, I think those are great points, David. I want to say, which floor do each of those patients live on?
Yeah, it may be the floor.
No. So I think, from my perspective, I think it's always good to have both good oral options and good biologic options. I think some patients are truly needlephobic because I've tried to convince them to go on biologics and I could not convince. But I would say those are likely few in between.
Yeah, they get their vaccinations once a year, most of them. So 4 shots a year. Come into the office, we'll give you the shot.
Yeah.
Right? But that,
Yeah. No, I think, when we're thinking about this, probably I would say when you're looking at the moderate to severe spectrum, right, probably a bit more on the moderate spectrum rather than the severe. Like the really severe, I think this, biologics works for the whole thing, and then this is indicated for the whole, it's the same indication, right? But I think in the real world, probably, more toward the moderate than the severe for the oral medication. I mean, it's the best oral in terms of the benefit risk analysis thus far, completely agreed, but the efficacy is not that of, let's say, ixekizumab or risankizumab or guselkumab that we talked about.
And what if the patient has PsA? Would you still use this drug or would you not?
I would, because they have phase 2 data showing its efficacy for PsA, and its phase 3 data is ongoing, and then MOA makes sense as well. So I think it's probably just a matter of time before the phase 3 data are completed and they will seek an indication in PsA. And the phase 2 data looks good for PsA, so.
Do you ever add this on to a biologic?
I do. So there's a sentence in the PI, in the prescribing information. I'm also a big fan. I like to unfold it and then but I love the PI actually. And so so there's a sentence in there that says deucravacitinib, Sotyktu, should not be combined with potent immunosuppressants. Now, I personally do not think the biologics we give for psoriasis or AD as potent immunosuppressive. That's my personal interpretation. And then what I have seen actually, and I have a number of patients in this, you treat them with a biologic and they're not getting better. You know those kind of rare birds. And I actually would add Sotyktu to it. I would add deucravacitinib to that. And because they have slightly different MOAs, even if you have IL-23 inhibitor and then add deucravacitinib, what I see is that you can take a patient who was really bad, but you could only get them to moderate with their biologic, and you add deucravacitinib, and you can actually get them to mild. So I have a few patients like that. Insurance is usually the sticking point, but fortunately, actually, I've had success actually getting both of those approved. So, depending on the insurance, but it's definitely worth a try in your difficult to treat patients.
So are you fighting the battle with the insurance to tell them that biologics are not potent immunosuppressives?
Oh no, I don't highlight it. It's one of those, I don't ask,
If they
ask, then
yes,
I
if they
justify.
ask.
Yes,
Okay.
yeah.
Yeah, I think the question that was asked is really important. Where do these drugs fit in? What's the patient for deucravacitinib? And I think when I see that data, just a 16 weeks of separation between apremilast and deucravacitinib, I would say any of us that are prescribing apremilast would say, when you look at this, say, well, those are all deucravacitinib patients. And then what Dr. Armstrong said really eloquently is that on the mild side of moderate, that's probably your sweet spot if you're thinking about a first-line place for deucravacitinib.
And I think for me, apremilast still has a role as well, and I think where I have used it is in my patients that have had solid organ malignancies, where we don't have another option. So if they do need to go off of their biologic, I have transitioned those patients to apremilast and have had some success there. If anybody else?
Agreed.
Yeah, and remember it has that mild indication. So let's say you have that really stubborn scalp or a stubborn groin or something like that. It's not a bad choice. And remember, it's also approved for Behçet's disease, apremilast. So people with those horrible mouth sores, and they may get sores in their groin. I have patients on that for that reason. Like, let's not forget, doesn't go out with the bathwater. It's got an interesting mechanism, and it's a very safe drug, although sometimes a little tough to tolerate. But you know, you're never going to lose a lot of sleep because someone was nauseous or had diarrhea. You're going to have to stop the drug, but you're not like saying, oh my God, what have I done, kind of thing, right?
And yeah, same dosing.